this is the MR image of the brain, T2 weighted image, axial section, in which I can see an altered signal intensity lesion in the region of the pineal gland, which is predominantly hypodense with some hyperdensity, which is causing a gross hydrocephalus. I would like to see in this some other images. Can I see post-contrast images or flare images? No, sagittal.
This is the post-contrast image.
Yes, ma'am. This is sagittal image post-contrast, which shows the same lesion, which is showing enhancement and some areas of signal void, which can be focal calcification. Keeping in view the location of the lesion, my differentials are pineoblastoma and or germinoma. Next, I would refer the patient. I would like to know the history of the patient. And first of all, the patient will be sent for this for a VP shunting for this hydrocephalus, and then referral to the neurosurgeon for the proper management.
Okay, so the lesson for this case is no one will show you this image in the exam. Remember this, right? So when you will have CT scan axial image, and I'm sorry, I don't have the CT scan of this patient, but that will be even more isodense to the brain than this area. And at times you will have a lesion which does not show these margins. It's a bit clearly visible. The purpose to show this CT scan that whenever you see hydrocephalus, always look for the point where it is the dilatation is ending, and try to look for the cause over there. This is an obvious lesion, but at times they can show you a small pineal gland tumor or small colliculus lesion, the glioma from the quadrigeminal plate here, and that is causing the occlusion here in the proximal hydrocaph. So if you see such dilated ventricular system, go to the root cause. Do not keep describing the ventricles and the mass effect, because you will lose time in doing that. So yes, appropriate. You should know the differentials of midline lesions in children and adults at all levels. Foramen of Monro, third ventricle, posterior to third ventricle, cerebellar vermis along posterior margin of the fourth ventricle. It's very easy to remember this way, and it's better that you open an axial image on the internet or somewhere, and then you revise your all list for that, so that you don't confuse things. And also at times they show you the post contrast images. Always try to differentiate the pineal lesion from the tactile plate gliomas. This is not a glioma at all. The enhancement and everything, it's very obvious. But at times, a small pineal cyst or structures, if the candidates are not paying attention to the tactile plate and the pineal gland, they can mix up these two lesions. So be careful reviewing this area, please.
Provided images of the chest X-ray of mature skeleton, frontal projection, showing there is a myocardium along with the pulmonary dilatation of the pulmonary artery, along with the aorta notch appear normal, and there is CP angle appears acute, and there is a pruning of plethora, increased vascularity on the upper lobes, representing plethora of vessels. Plethora, and however, and pruning of the periphery vessels, finding suggestive of the pulmonary arterial hypertension, along with the mitral valve stenosis.
Mitral. So what is this bulge here?
This is represent the pulmonary artery conus.
So what is the main,
Pulmonary
if
arterial
this
hypertension.
area is prominent, what is the most common cause of this prominent pulmonary conus?
Pulmonary arterial hypertension.
And that is due to what?
In children,
Usually atrial septal defects. I'm basically not a cardiology person or pulmonology, but atrial septal defect is the commonest cause with this appearance, because that leads secondarily to the hypertension with enlarged mediastinum vessels and the engorgement. But if this wouldn't have been here, and you have seen the chamber enlargement and increased retrocardiac density and splaying, and the pulmonary venous engorgement and everything, without this and other findings, even the chamber enlargement is different for this case. So mitral stenosis is not the diagnosis for this case. Just review the mitral valve disease, atrial septal defect, and combined mitral stenosis, mitral regurg. Just write these buzzwords and review the X-ray appearances, right? This was just to show you that one of these cases, the pulmonary arterial hypertension, pulmonary venous hypertension, atrial septal defect, ventricular septal defect, in either peds or obviously the peds, and the cardiology cases of mitral valvular heart diseases in adults. The differentiation of arterial venous hypertension, it is present, it is shown in OSCE, the TOACS, as well as Viva. So you must get familiarized to appearances of all these pathologies on plain X-ray.
Okay, so these are the axial sections from the T1 and T2 MRI brain examination. So on this scan, I can see that there is abnormal signal intensity which is involving the frontal sinus bilaterally. It is hypointense on T1 and it is heterogeneously hyperintense on T2. I can see that there is also associated surrounding overlying soft tissue abnormality as well. Yes, this one. And the bone is also appearing to be abnormal. The bone around the frontal sinus is also appearing to be abnormal. So this likely appears to be an abscess formation, or in fact an abscess formation involving the frontal sinus as well as its overlying subcutaneous soft tissue. So this likely appears to be a Pott's puffy tumor.
Okay, so what is the cause here?
So basically it is a sinusitis infection which causes the erosion of the bone and then extends into the adjacent subcutaneous soft tissue, which and it may also extend into the sometimes they may also show intracranial extension as well.
So what do you think, there is intracranial extension or not?
So on this coronal section, I can see that there is enhancement of the dural lining as well. The dural lining are enhanced, so they may be associated meningeal infection as well.
Okay. Yes, the Nan has correctly mentioned that when you see such abnormality, the surgeons, they will ask whether there is intracranial brain parenchymal abscess or not. So you will have to be very careful reviewing images, all details on axial and sagittal and coronal, because if you see parenchymal abscess, they go for the craniotomies. Otherwise, they just clean the sinuses and give antibiotics to treat the meningeal involvement. So your words and reports are the clue towards the treatment.
Madam, is the left orbit also involved?
Okay, let me see that. Yes, correct. The left orbit was involved. I remember the case. Right. There was intraorbital extension. There was osteomyelitis of the left orbital roof. And you should know the details, anatomy of the bone, that there is outer diploic space, inner diploic, cortex, inner cortex, and the diploic space. And if you come here, the bone is involved. So it was left frontal and the midline frontal and the left orbital osteomyelitis, intraorbital extension, and this all extends from the frontal sinus. And it was low on T2. I don't know whether you have reviewed it carefully or not. So there was low
Yes,
signal
there is
within
low
these
intensity
areas, and
directly,
this is
which can occur
confirmed
in fungal
aspergillosis.
infection. Yes.
It was confirmed aspergillosis on in the lab analysis.